If you were able to go to grand rounds at all yesterday, then you've heard some of this, and hopefully this will just be a little more in-depth on certain parts and the next step. But we're going to talk about, when we say MDROs, what does that mean, and what exactly are we talking about? How do we recognize risk factors for developing MDROs, which is multi-drug resistant organisms? How do we prevent transmission? And then what are some of these, and how do we treat them? So we see this happen all the time. We got some antibiotics that seem to be working, and then our organisms seem to evolve right before our eyes. And unfortunately, what's not happening is we're not getting any new antibiotics coming out to really combat these problems. And even if we do kind of see a stray antibiotic here or there, it tends to be in a class of antibiotics that we already have, when we could really use some new development of even new classes. So MDROs are bacteria that are resistant to what we consider the current antibiotic treatment or the standard treatment for that organism. So they become very difficult to treat because we have limited antibiotics that work. And so what we're talking about here is MRSA, so methicillin-resistant Staph aureus. VRE is another example, vancomycin-resistant Enterococcus. ESBLs, which is Pat's part of the presentation, but those are extended spectrum beta-lactamases. So we have extended spectrum penicillins, and that was a good thing to cover organisms that were now resistant to other penicillins. But then the bacteria started developing more beta-lactamases that even inhibit those antibiotics. And then penicillin-resistant strep pneumoniae, and that comes into play when we talk about meningitis, community-acquired pneumonia, where strep pneumonia plays an important role. So who's at risk? And this is our typical, when we think of severe infections and multi-drug resistant organisms, this is kind of the typical list that we think of. So patients who have existing severe illnesses, our HEMONC patient population. Patients with underlying diseases or chronic conditions such as diabetes or chronic kidney disease, CF. Patients who have invasive procedures, prolonged hospitalizations or repeated hospitalizations, and patients who are immunosuppressed. But, unfortunately, with the advent of MDROs, who is at risk is really everyone. Because especially when we start taking a look at MRSA, which now we have CA, which is community-acquired MRSA. So it's no longer a hospital disease, it's now community-acquired also. And this is where we kind of get everyone involved. So when we think of community-acquired MRSA, we think of the skin and soft tissue infections. We see a lot of cellulitis. So patients at risk, patients with chronic skin conditions, and we've seen that with our kids who maybe have very severe eczema, and they're doing this and scratching and itching, and they get skin infections on top of that. Close skin-to-skin contact. Our football players, our wrestlers. So again, everyone can be at risk. Poor hygiene, anything where you just have minor skin damage can potentially then result in a cellulitis. So prevention strategies, just kind of stand clear of everyone. So maybe kids have the right idea with their social media. They only have to worry about computer viruses instead of people viruses. So how can we prevent transmission? So from an organizational standpoint, Joint Commission tries to come in and help us with these things by saying we think that you should look at multi-drug resistant organisms and do some things about them. So Joint Commission comes out with standards. So we take a look at that. But we want to try and identify experts who can provide consultation, implement systems to where we can identify colonized or infected patients. That's a big one, and I think one that we still talk about and are working through. So we'll have patients that we know had an MRSA infection, and that's why they were admitted. But now that patient is going to go home and then maybe come back in and go to different clinics from an outpatient standpoint. And how do we relay that information from inpatient world to outpatient world in EPIC so that everyone knows? And then even in just talking to the patients, if they have some kind of MDRO infection, when they come back in, should they wear a mask? You know, what should all of that look like? And I think those are things we're still working through. Provide education and training. Appropriate antimicrobial use. And again, this was talked about at Grand Rounds. So we have our antimicrobial stewardship team. And right now we do have a multidisciplinary team that meets at 11, and they look at lab cultures, and they look at what patients or what antibiotics the patient is currently on, and try and make sure there's not a mismatch there between the organism and the antibiotic. Also, if we're able to narrow therapy. And then surveillance. So this is Terry Koss, fits in there as our infection preventionalist, and she is always looking at our susceptibility reports and patterns, and we try and monitor trends. So I don't think this slide is completely accurate, because truly I think it's more that we have 2 hours of caring for patients, and then I think we split the rest into EPIC documentation and hand washing. Okay, so then infection control, and you guys all kind of know what that would look like. So what have we done? And we talked about the antibiotic stewardship program, and we are working on the education portion, and we're doing surveillance and looking at antibiotic utilization. The antibiograms have been revised, and so those are giving, I think, a better depiction of what's going on here. And you can find those on the Med Resource Center. We've done a lot of hand washing campaigns. The ICU and the NICU, and I think HEMONC is also working on this, doing bloodstream infection bundles, and then ventilator-associated pneumonia bundles. And I know we are revisiting a lot of those to see if there are other things that we can tweak to, again, reduce our bloodstream infection rates. And we also have the surgical site infection team that has done a lot with making sure that our antibiotics are being dosed appropriately prior to surgery and then even during surgery. And the Med Resource Center. So if this comes up ever, there is an antibiotic stewardship tab that we can go to, and we can find a lot of the IDSA guidelines for different disease states. We can find our current antibiograms on here. We have also included our vancomycin dosing guidelines. And then the pharmacy is also giving recommendations on when it might be appropriate to switch from IV antibiotics to oral, and those guidelines are on here also. She's not going to show us things, so we'll just keep going. Okay, so in the hospital, of course, now we know that we can find MRSA everywhere. So MRSA, this is the MDRO that I'm going to talk about today. And when patients are colonized, this can be found in their nose and pharynx. So therefore, the most common infections we see are skin and soft tissue, so cellulitis. But we also know that MRSA can cause severe pneumonias and sepsis. So, community acquired. Obviously, if a patient is being seen outpatient, then most likely it would be community acquired. Or inpatient if it's a noted infection within 48 hours. Also, for it to be considered community-acquired, they wouldn't have had necessarily a medical history of having a hospital-acquired MRSA in the past. They would not fit these other criteria of having been hospitalized or being in a nursing home or hospice, dialysis, or recent surgery. And also, if patients have permanent indwelling catheters or medical devices, then they're more likely to have a hospital-acquired MRSA. And the reason that's important, so why do we care to differentiate the two, is that the antibiotic treatment between community-acquired and hospital-acquired looks a little bit different. So community-acquired MRSA tends to be resistant to beta-lactams, which all MRSA is resistant to beta-lactams. They all are also resistant to macrolides, so your zithromax, your erythromycins. But community-acquired is susceptible most of the time to things like Bactrim, Clinda, fluoroquinolones, which would include Cipro or Levaquin, and then the tetracyclines. So just to take a step, when we have methicillin-susceptible Staph aureus, these are still not covered by our penicillin and cephalosporins. And the reason that is because penicillin and cephalosporins have this beta-lactam ring. And methicillin-susceptible staph, so any Staph aureus, will cleave that beta-lactam ring, which makes it resistant to those antibiotics. So for MSSA, we cannot use ampicillin alone, but we can potentially use ampicillin sulbactam, because sulbactam is our beta-lactamase inhibitor, so it extends the spectrum of the ampicillin. And it does this for methicillin-susceptible Staph aureus, but it also does this for Moraxella and Haemophilus. So sometimes you'll get those Lukens cultures back, and they will say that it's Haemophilus or Moraxella, and then it will tell you whether it's a beta-lactamase producer or if it's negative for beta-lactamase. And that kind of gives you an idea of whether I can use ampicillin or amoxicillin alone, or whether I need to step that up to an augmentin or unicin. So if it's a beta-lactamase producer, I need to add that sulbactam. So beta-lactam antibiotics bind to the proteins that are responsible for cell wall synthesis. Now, if my penicillin binding protein is altered, then the antibiotic can no longer inhibit cell wall synthesis. So I can maybe take care of my beta-lactamase problem, but I still have to be able to bind to the penicillin binding protein. So how are these organisms going to become resistant? They're going to alter the penicillin binding protein. And they do that through the MECA gene. And it's part of this whole chromosomal cassette. But MECA gene expression produces an altered penicillin binding protein. So this is what makes penicillin, even if we're not cleaving that beta-lactam ring, still not able to work against Staph aureus. So there's 4 types of that whole chromosomal cassette, and they each kind of have a differing pattern of drug resistance. So the community-acquired MRSA only carries the MEC4, which carries that MECA gene and alters penicillin binding protein. The strains that are found in hospital-acquired or nosocomial MRSA also cause resistance to some of the other antibiotics. So hospital-acquired MRSA becomes even more difficult to treat than community-acquired. Community-acquired MRSA also has variable resistance to erythromycin. So sometimes erythromycin might work. Most of the time it would not be a drug that we would pick to use because there is a pump that pumps the erythromycin out of the organism. But what that does is this gene also causes inducible resistance to clindamycin. So So you have to pay attention to, at your institution, is clindamycin susceptible or resistant to your community-acquired MRSA? And right now, I think our last antibiogram showed about 90% susceptibility to clindamycin. So we still feel that that is a fairly reliable antibiotic to use, but it's a number we would pay attention to. This is just the test that they used to do in micro to show whether something was going to potentially induce resistance. So this is your erythromycin and this is your clinda. And around the clinda you can see that it looked like it was killing the organism, except not as much where that erythromycin disc is. And that's because those bacteria are becoming resistant to clinda in the face of the erythromycin. So if we have a community-acquired soft tissue infection for an outpatient, how are we going to treat that? So empiric treatment, we could look at something like cephalexin or augmentin, which we said will work. Maybe if it's MSSA, but not if it's MRSA. So then we have clinda. And the nice thing about clindamycin is it covers both staph and strep. Because the thing you have to remember is strep is also still potentially a culprit in these cellulitis. So if you have a patient who maybe has impetigo or something where you think strep is on your list, then you do not want to use Bactrim. So Bactrim is good for MRSA, but it's not so good if you have a group A strep infection. If you have something that can be drained and cultured, then that's the way to go. And a lot of times, if you have a skin infection where there's something to drain, drainage is maybe all you need to do. So draining is always the number one. But if you have a culture-proven MRSA, then hopefully you'll get susceptibilities back. But then clindamycin, Bactrim, minocycline, and finally Zyvox are all usually alternatives. So what do we do with those kids who have recurrent infections? And there are IDSA guidelines for MRSA, and they talk a little bit about decolonization, when to use it, where to use it. So if you have a patient where you're just really seeing this repeatedly, then that might be a patient where you want to look at trying to decolonize them. So the nares is the most common site of colonization. So criteria for trying to decolonize a patient would be to know that you have Staph aureus colonization, that you've had multiple infections in that particular patient or within the household, and you want to do this when they are not actively infected. You can use mupirocin, which is Bactriban, intranasally twice a day for 5 to 10 days. There are also things in there about doing chlorhexidine baths and stuff to go along with this. If you are treating a household, you want to treat everyone at the same time.
Can I ask a question?
Yes.
What is our current susceptibility of MRSA to Bactrim for community acquired?
Do you know those numbers?
It's pretty good.
I think, yeah.
I think it's 100% actually.
Okay, I knew it was pretty high, but I wasn't sure exactly where. Okay.
So the big issue people have with Bactrim, of course, is what's its adverse effect that everybody always worries about.
Stevens-Johnson.
Right. And then if you have someone who's ever seen Stevens-Johnson's, then they get really nervous about prescribing Bactrim. So it is serious and severe, but Bactrim is a good alternative as long as you don't have a sulfa allergy. Right.
Or abscess, right? It won't get to the abscess, right?
So, and an abscess, again, really the best thing there is to try and drain the abscess because antibiotics just in general don't penetrate very well. So hospital-acquired MRSA. So the nice thing is, with all of the bloodstream infection bundles and the fact that the government's not going to pay for bloodstream infections that occur in the hospital, hospitals have done a pretty good job of trying to decrease these numbers. And there are 58% fewer BSIs in hospital ICU patients in 2009 compared to 2001. And from Staph aureus, that's been reduced by 73% overall in looking at that time frame. So how do we treat these serious, severe infections when kids are in the hospital? So vancomycin, when you would look up the dosing before, there's dosing of 10 to 15 milligrams per kilo per dose. And now we are recommending to just start with 15 milligrams per kilo per dose empirically. Because if you do have an MRSA, you don't really know where that MIC or mean inhibitory concentration is going to fall out. So we want to make sure that we're empirically treating them with a high enough dose. Again, we can also potentially use clindamycin. And then Zyvox is another alternative. In adults, the guidelines now are also to treat much higher, 15 to 20 milligrams per kilo per dose, and adults would give that every 8 to 12 hours, with the max dose at a time being 2 grams. And it's dosed based on actual body weight. And again, this is much different than the normal 1 gram every 12 hours for every adult, no matter their size. And again, in pediatrics, we're doing the 15 milligram per kilo to start out with every 6. Trough monitoring, we want to get that when the patient is at steady state. So we're getting that prior to the 4th or 5th dose, with our goal trough level being 10 to 20, and if we're really thinking MRSA, 15 to 20. And we want to base that on the infection site and the organism. So infection site also comes into play if we are trying to treat a CNS infection, if we're trying to treat an osteo. Vancomycin does not penetrate well into tissue. Even pneumonia for the lungs. So we want to make sure, because we're only going to get a portion of the drug into that tissue site compared to what's in our serum, we want to make sure that we're treating them with high enough levels. So the MIC, so what is that? That's the lowest concentration of your antibiotic that will inhibit visible growth of a microorganism. So this is kind of that lab value. So for vancomycin, what you will see is you will see either MICs of 0.5, 1, or 2. And if your MIC is 0.5, then lower troughs. So if you're around 10, then that would be acceptable. Again, you still have to pay attention to where is the site of the infection though. If your vancomycin MIC is 1, then you really need troughs of 15 to 20 to make sure that you're high enough above the MIC of the organism. With an MIC of 2, even with a trough of 15 or 20, you're probably not necessarily going to get there with the dosing regimens that we have. So you may, at this point, you probably are needing to think about alternative therapy. And here are some graphs to show that. So this is a study that was done in 2011, and they looked at the probability of achieving an area under the curve over MIC. So we talk about looking at trough levels with vancomycin, but when they look at vancomycin's efficacy, it's really the area under the curve. So how much dose am I getting, and the time above the MIC all kind of comes into play when we look at area under the curve. And there's this ratio of greater than or equal to 400 that they kind of look at. So in this, they used, this is adults obviously, they used these different dosing regimens of 0.5, 1 gram, 1.5, and 2 grams every 12 hours. And they were looking at troughs that were between 10 and 15. And when the MIC value was 1, their percent of actually getting to their target of having an AUC to MIC of greater than 400 was at 80% on the 1.5 grams every 12 and the 2 grams every 12. And these trough levels were between 10 and 15. So what they found, one thing was that trough levels, while a surrogate marker, maybe aren't the best marker for vancomycin, but it's kind of what we have. And also that at the lower dosing regimens, they're not getting there. So they definitely needed to dose patients higher. The problem is, as you dose vancomycin higher, you run into more risk of nephrotoxicity.
What question, Stacey?
Yes.
Before you go on the case study, I wait you done with this.
This confusing data. So here, what they did was they said, okay, now we're going to try and keep our troughs between 15 and 20. And they used these same doses. And with troughs of 15 to 20 for an MIC of 1, they were 100%. So our trough, now, if we're keeping it at that goal, we can treat with MICs of 1. And of course, they were also looking at that AUC to MIC ratio. They said, well, there might have been some of these patients that actually hit that ratio without needing to have a trough that was that high. Because again, what they found with this was, yes, we got where we wanted from an efficacy standpoint, but we saw more nephrotoxicity. And again, with this number of 2 over here, we're not reaching there. So if you have an MIC of 2 for vancomycin, you're switching therapy. You're probably not using vanc because you can't use high enough doses without causing kidney issues. Okay.
So I was paying attention to this after I went to Alter's lecture yesterday. So I had a patient this morning that I presented on in rounds, and she had MSSA interleukins.
Okay.
And so I was looking at the MICs, and had her on Bactrim, but the MIC for Bactrim was actually the highest one. How does that relate to other antibiotics? So
It doesn't.
Okay. Okay.
So you can't, MICs are specific for the organism and the antibiotic.
Okay.
I'm saying that correctly right now. Okay. So this, for these MIC values, this only pertains to vancomycin.
Okay, that's what I wanted to check.
So different antibiotics have different MICs where they become intermediate and resistant.
Okay.
Because you can reach different concentrations in the serum
Okay.
with different antibiotics.
So I was wondering if I should go into a higher dose of Bactrim at that point, or if I just okay.
No,
Okay,
you can
good.
still
That
trust,
clarified.
yes. So in the lab, you can still trust what their susceptibility and intermediate and resistant is, but those numbers will look different.
So if we see a report that comes out and we have 4 or 5 or 10 antibiotics listed, we don't necessarily want the one that has the lowest MIC. That's not necessarily true because it's comparing apples and oranges then, is that right?
Correct.
Okay.
There are some times where antibiotics might have the same MIC values for their susceptibility and intermediate, but yes, it's comparing apples to oranges. Okay, so now we're going to do one patient case. So this is a 14-year-old admitted to the PICU with severe bilateral pneumonia. The patient is positive for influenza A and is requiring ventilator support. So viral pneumonia with what we are assuming now is a secondary bacterial infection. What antibiotics would you like to start? Okay, Levaquin, all right. Which is actually a decent community-acquired pneumonia antibiotic for a 14-year-old. What do we always start all our patients with?
Processing.
Yeah, okay, so Rosefin, vancomycin. And in this patient with an influenza A, secondary bacterial, who has a severe pneumonia, Staph aureus is definitely a player. So thinking ahead that adding vancomycin, that's definitely a reasonable option in this case. So they started them on Rosefin and vanc, and our culture is positive for MRSA. So now what would you like to do?
take off the receptor.
So that's the question. Yes, can we get rid of the receptor?
So is the final culture or something?
So in this patient, we do want to make sure that we are dosing appropriately. So we want to give the 15 mg per kilo Q6. And we did that and we came back and our trough level was 10. We know that we have MRSA. We don't have the susceptibilities back yet, so we don't know what the MIC is. So would you adjust your dosing? Yes, absolutely. So we increased to 20 milligram per kilo Q6. We now have a trough level of 15. Their lung function is not improving. They're still spiking. So from a clinical picture, we're not getting better. The MIC comes back at 2. Even if this all was true and our MIC came back at 1, what would you like to do? Change. Levaquin.
Sorry.
Yes, that's what you mean. Linezolid. Yes. So we would probably switch this kid to linezolid Zyvox and DC the VANC. And then is oral therapy an option? Eventually down the road. So the nice thing about Zyvox is that it does have good bioavailability. So at some point, as your patient improves, you can switch from IV to oral with the same dose. The biggest thing we notice with the Zyvox is drug interactions. SSRIs, methadone pops up, all as having the potential to have serotonin syndrome. So again, linezolid has good oral bioavailability. We do have to monitor CBCs weekly when they're on it because it can cause myelosuppression. And then these are all the drug interactions that we have to worry about. Are there any questions on MRSA?
I do have a question. Several slides ago, you mentioned soft tissue infections and VANCO. VANCO not being a good choice for a soft tissue infection.
No. So what I was really looking at there was what outpatient options do we have? So vancomycin can still be a reasonable choice for community-acquired MRSA, and it would work from an inpatient standpoint if you have a cellulitis. But there are other options, so you wouldn't necessarily have to jump to vancomycin.
So there's no reason, so I'm asking this because that's like the bread and butter of our practice. And it's very physician dependent. There is no good reason to go right to vanco when we have Clinda at 90%, or we should go to vanco, with Clinda being 90+%. Effective in the community, and ours are all community acquired. I mean, we're definitely seeing failed outpatient therapy.
So if they haven't, right, so if they haven't already been treated and maybe failed some kind of outpatient.
Typically Bactrim is what they failed, because that's what the pediatricians like, because it's BID dosing and it tastes good. So that's typically what they failed.
Because Clinda's not.
It tastes bad and it's TID, so compliance is poor.
Right. So really from our susceptibility patterns, Clinda is still a reasonable option at that point. Or if there is something to drain and we want to start with vanc but then can tailor down to clindamycin, then that would be a reasonable option too. But yeah, we're trying to reserve as best we can our vancomycin.
Is Clinda's bioavailability as good PO as it is IV?
Yes. So today, this doesn't have anything to do with MRSA, but we had a patient in the ICU who had come in for what maybe could have been a meningitis. Didn't necessarily look very bacterial, so probably a viral encephalitis. But we always rule them out. So they put them on ceftriaxone, which makes sense because meningitis, we worry about strep pneumoniae. And we talked about penicillin-resistant strep pneumo. So we would start with Rocephin or a third-generation cephalosporin. But what we are not seeing, thankfully, at our hospital is a lot of cephalosporin resistance with strep pneumo. So they had started the patient on both Rocephin and vancomycin. But in this situation, they're not going down we think this is staph. So we probably don't need to necessarily add vancomycin to those meningitis kids if we're just thinking of our typical organisms. So again, we're just trying to, because we don't have a lot of other antibiotics and other choices out there that are wonderful to use in pediatrics, trying to reserve vancomycin, but we know with the increase that we're seeing in MRSA that we're going to use it, so we want to use it appropriately and dose it appropriately. Yeah, high enough to actually work. And then I would be remiss if we didn't talk about Dr. Kness's renal patients. So that is something to keep in mind, that when you do have patients whose renal function isn't what our normal healthy kids are, vancomycin will accumulate, so we do have to pay attention to those kids and dose adjust. But we still want to dose them appropriately, so we don't want to dose adjust too early that they're not being treated for their infection.
So is a renal panel indicated before you ever start, or just monitor it periodically?
I would like a renal panel
Prior
when
to
you
starting,
start,
or as you start?
because it would be good to know what their baseline is. Because you want to know if when I treat with vanc, have I now, how am I going to know if they doubled their serum creatinine if I didn't know where they started? And with vancomycin and the higher dosing and nephrotoxicity potentially coming more into play, I think it's good to know where they start and then to monitor it. Anything else? All right, then Pat will take over.
I have about a half-hour presentation. Do you guys have time to do this, or do you want me to get started and do half, or rush through? I can
Is
do
it
that.
how similar is it to yesterday's?
The last half is similar to yesterday. So whatever, I'm happy to do whatever you guys want.
Just start and see what.
Just start and go over it.
How about that?
See anybody running for the door, so.
Yeah.
Onward and upward.
Color.
I'd be like, how did you? Probably is such a sign of it. Yeah.
Okay, so we're going to talk about extended spectrum beta-lactam antibiotic resistance. And this is where we're going to go with this topic. And all over the park. Hopefully we'll end up back home so you're comfortable with what we're talking about. We're going to define the problem, discuss the mechanism of resistance, discuss some risk factors, and then discuss preserving antibiotic efficacy for antibiotics. And that's the part that's going to be similar to tomorrow, or yesterday, or whoever was here yesterday. This is just an acronym of our resistant microorganisms that we're pretty much facing today. The first two are our gram-positives, but the bottom four are going to be the ones I talk about today, and those are our gram-negatives. So, Enterobacter cloacae, the resistance pattern from 1993 to 2004 in our U.S. ICUs is almost doubled. Pseudomonas has taken a 5-fold increase. Pneumo has taken about a 2.5-fold increase, and Acinetobacter about a 4-fold increase during that time span, about 11 years. So we're facing an increased resistance. The problem is that we don't have any new antibiotics. There's only been one new class of antibiotics developed in the last 30 years, and that's our oxazolidine dinones, and that's linezolid, okay? The other one, the lipopeptides, they've actually been around for 50 years, but, and you might recognize them as our polymyxins, our colistin, some of the really old antibiotics. The newer lipopeptides would be daptomycin or the echinocandins. Both of those would qualify in that category. So they're in there, but they're not new, new entities at all. So what we have to do is actually preserve what we have, okay? So we're going to start with a case. This is a 4-year-old female who was admitted with aplastic anemia and bacteremia. The blood cultures collected during the first week were positive for E. coli resistant to ampicillin and narrow spectrum cephalosporins, okay? So just kind of keep that in mind for a second. Over the next 3 weeks, she receives 8 antibiotics, okay? We still have persistent fevers and bacteremia. We get cultures again, and this time, what we see on week 4 is E. coli isolates demonstrating the following susceptibilities. We're resistant to ampicillin, cefazolin, ceftazidime, ceftriaxone, and cefepime, and aztreonam, but we have some susceptibilities still available to us. So we're going to kind of go through this pattern and determine exactly what happened during those 3 weeks, okay? So there are, Stace talked about some mechanisms of resistance. The efflux pumps, that's primarily gram-positive. Altered targets can be gram-negative and gram-positive. Altered permeability is a gram-negative phenomenon, but the most important one, and the one we're going to be talking about today, is the production of inactivating enzymes. And this is the major mechanism of resistance of these organisms. So in order for penicillins to work, we need an intact beta-lactam. And as soon as that beta-lactam becomes destroyed, it can no longer bind to the penicillin binding protein, so it's no longer active. The problem is all of these compounds contain that beta-lactam. So once you disrupt that beta-lactam, all it takes is a few amino acid adjustments, and pretty soon we're not able to be effective with our cephalosporins. A few more amino acid adjustments, and we're not able to use our monobactams, and then a few more amino acid adjustments, and we're no longer able to use our carbapenems. So this is just sort of a scale, and you can think of it as we're going to start off with our wild-type bacteria, and we're going to treat with penicillin. So what the microorganism is going to do is create penicillinases to break that down. So we thought we'd be smart and try to treat that organism now with cephalosporins. But again, they develop this resistance, they mutate, and they can develop cephalosporinases. So next we go on to, okay, we're going to treat this thing now. We're going to go with carbapenems. But they're still smart. What we're seeing is KPCs, and they can mutate again and actually destroy the beta-lactam rate. So the beta-lactamases, we're going to start with the beginning of that slide, okay, up at the top. The very first one was very shortly after penicillin was developed in 1940. But the first plasmid-mediated beta-lactamase in a gram-negative bacteria was found in 1965, and it was in an Escherichia coli. And actually it was in Greece that they found this. This enzyme is named after the patient that experienced this infection, and her name was Timoniera. So now she has an enzyme named after her. Isn't that awesome? So much for HIPAA, right? It's now responsible for 50 to 60% of the plasmid-mediated ampicillin resistance in E. coli, and it has migrated into Haemophilus influenza and Neisseria gonorrhea. The TIM2 enzyme is a biochemical twin, and it's only different by one amino acid. Both of these are capable of hydrolyzing penicillins, first-generation cephalosporins, but are unable to attack the third-generation cephalosporins. So if you think back of our susceptibility pattern that was going on initially, this might help. A related but less common enzyme is SHV, and they quit using patient names for these finally, so it's called the sulfhydryl variable produced, and it's produced by Klebsiella pneumonia. So we look at our case again. So what do you think the enzyme was that was responsible for this pattern? Probably the TEM1 or TEM2, okay? Remember, it's E. coli. The SHV was produced by the Kleb. So more than likely, looking back at our pattern of susceptibility, we either have a TEM1 or possibly a TEM2 going on there. Let's move down that scale to the extended spectrum beta-lactamases. They are mutant enzymes that produce a broader range of activity than their parent molecules, and they can hydrolyze penicillins, third-generation cephalosporins, and fourth-generation, including cefepime, and the monobactams. They do not affect cefoxitin, the carbapenems, or the beta-lactamase inhibitors, such as sulbactam. Okay? There are some non-classical ESBLs that are described, and these are like the CTXM. They're found in multiple genera of Enterobacteriaceae, and there's over 130 of those now described. They preferentially hydrolyze cefotaxime, and they can confer resistance to all the cephalosporins. Another one is AMP-C. They are encoded on chromosomes, and they can be inducible. If they're inducible, they can suddenly appear and become extremely resistant. Overexpression can confer resistance to, again, these compounds, the beta-lactamase inhibitors, cefoxitin, and the third-generation cephalosporins. They are susceptible to the fourth-generation cephalosporins and the carbapenems. And they also may be plasmid mediated, which means that they can not only appear in one microorganism, but go to a totally different species. They can just share it around the table. So looking at her susceptibility pattern now, again, she's resistant to ampicillin, but she is susceptible to ampicillin clavulanic, cefoxitin, and our carbapenems. So what would you suspect our cephalosporinase to be in this case? You think it's an AMP-C or an ESBL? ESBL. Next on the line is the carbapenemases, and again, they can inactivate the carbapenems as well as all the other classes of beta-lactams, and they are found in the Enterobacteriaceae, Pseudomonas, and Acinetobacter. The genes controlling these carbapenemase production are transferable again by plasmids, so we can pass this around to different microorganisms. The beta-lactamase inhibitors, such as clavulanic acid, tazobactam, and sulbactam, are inactive against these enzymes. But they are potentially susceptible to colistin. And sometimes we've had to use colistin in some of our CF patients that have developed this problem. If you're reading the literature on beta-lactamases, you'll find out that there's two classifications. The Bush-Jacobi classification is more of a clinical classification, whereas the Ambler classification is more of a chemical structure type of a classification. So most of the beta-lactamases that we are looking at are the 2B and the 2BE, fall into this clinical category. So some of the risk factors for acquiring ESBLs, which I'm sure you're aware, is the length of hospital stay. We want to limit that as much as possible. Obviously the length of ICU stay, the presence of central lines, and Stace talked about IV to PO switch. It's extremely important that we get those lines out. Presence of gastrostomy and jejunostomy tubes, gut colonization, low birth weight, any prior administration of antibiotics, severity of illness, presence of urinary catheters, some of the things that you would normally expect. So the consequences. This was a study done and published in 2002, but they noted that the mortality rate in patients who had cephalosporin-resistant microorganisms was almost double that of the patients who had cephalosporin-susceptible infections. The length of stay was significantly longer, and the cost of therapy was almost double. So, the Infectious Disease Society of America has developed antimicrobial stewardship guidelines whereby we can try to limit the development of resistance. We can try to limit the toxicity of the antimicrobials that we're using, and we're going to try to improve outcomes using these strategies. They recommend 10 of them. We're going to include 7 of those in our efforts, and the 7 we include are the ones that have the strongest recommendation and the highest quality of evidence behind it. So one of those strategies was to optimize your therapy, okay? How are we going to optimize use of the antimicrobials that we have available to us today, okay, since we don't have any new classes? If you give a patient an injection of an antimicrobial and you were to get serial serum concentrations following that, you could come up with pharmacokinetic parameters like the Cmax, the half-life, the area under the serum concentration time curve, but none of that's going to make any difference, and you can't predict efficacy based on just those pharmacokinetic parameters. It's only when you compare those to the MIC that you can start to predict efficacy, okay? So we can divide our antibiotics into 3 different profiles. Those that rely on the peak to MIC ratio, those that rely on the time above the MIC, and then the AUC to MIC ratio. And Stace talked about vancomycin being in that category. So again, we're going to divide them into 3 categories. Concentration-dependent antibiotics are your aminoglycosides. And again, we're going to try to achieve a high peak to MIC. Our time-dependent antibiotics are the cephalosporins. Again, we're looking at a time above the MIC, and then this falls into a hybrid. And we're going to look at AUC to MIC ratio, but the surrogate for that is trough, okay? Trough to or MIC. This was a study done in 1987, and they looked at about 280 patients. They looked at the response rate comparing that to the maximum peak to MIC ratio, and they noticed a significant correlation there. In fact, it had a p-value of less than 0.0001, so extremely significant. So we took that idea and we applied it to patients, and what they noted was that way back in 1984, those patients who had initial serum peak levels of less than 5, 79% of those survived. However, if we had peaks of greater than 5, almost 100% of those survived. So what we've done is gone to once daily aminoglycoside therapy. Now how can we do that? Okay. The reason we can do that is aminoglycosides have a post-antibiotic effect. So once they drop below their MIC, they're still able to be antimicrobial, okay? They can still stop that penicillin or that protein synthesis. So even though we drop below the MIC, they're still effective. So we've taken this information and applied it to our pediatric population. And this is a meta-analysis of several different studies that were done. They were done in the PICU, they were done in the NICU, they were done in our CF population. They were done in patients with urinary tract infections. And they were done with amikacin, tobramycin, and gentamicin. And what they noticed with the pool failure rate was actually lower with the once daily dosing. The secondary nephrotoxicity was much lower with once daily dosing. And then our ototoxicity was about the same. So once daily dosing appears to be very beneficial for the patient. And it's one way we can optimize our therapy, okay, of the existing antimicrobials that we have. How do we monitor once daily dosing? What we've implemented is a 2 and 6 hour post-infusion level, because if we were to wait until 24 hours out to get a trough, it would be 0. And then we couldn't calculate a half-life, and we couldn't predict what the best regimen or best dose would be. So if you look in EPIC now under once daily aminoglycoside therapy, you will see this panel. We can order a 2 and a 6 hour post-infusion panel. Now switching to the beta-lactams, how are we going to optimize those drugs? Well, again, we're trying to maximize the time above the MIC. There's 3 ways we can do that. We can either increase the dose, give a higher dose, or we can increase the dosing frequency, give them shorter together, or we can increase the duration of infusion. The optimum time that these antibiotics should spend above the MIC, for carbapenems, it's 40% of the dosing interval. For penicillins, it's 50% of the dosing interval, and for cephalosporins, it's 60% of the dosing interval. and that's for maximal efficacy. So if we were to try the first step, okay, we're just going to increase the dose. Say we double the dose. What is that going to buy us in terms of increased efficacy? The only thing it's going to buy us is one extra half-life, and the half-life is only 1 to 1.5 hours. So this is all we're going to get, okay? At the same time, what we're doing is doubling the cost of therapy. So it's not very cost-effective. However, if we increase the infusion time, we can increase this time above the MIC significantly. And this was done with meropenem. I have a couple different examples of this. This is tazo done the same way. Again, this is 2 grams given as a 4-hour infusion, and we significantly increase the time above the MIC. The other thing we've done by doing this is avoid these high peaks, which could be contributing to our toxicity, such as nausea and vomiting. Okay? So let's look at our probability of target attainment when we look at 3 different dosage regimens. Okay? We're going to give 3 grams every 6 hours.